بنشكر الأستاذ الدكتور مجاهد أبو المجد على محاضرته القيمة، ونقدم أستاذة الدكتورة رشا طريف أستاذ البيدياتريك اندوكراينولوجي عين شمس يونيفرسيتي، هتكلمنا عن التشايلدهود اوبيزيتي. مش كده كان فارماكوثيرابي بي ذا انسر، ودي مهمة جدا لأن دلوقتي children obesity is an disease، مش not the disease، أنا قصدي وباء.
صحيح.
اوكي اتفضلي يا دكتورة.
صحيح. بسم الله الرحمن الرحيم ومساء الخير على حضراتكم. بشكر حضرتك على التقديم الجميل، سعيدة بوجودي مع حضراتكم وسعيدة بوجودي في ثايرو ايجيبت، وبشكر دكتورة غادة ودكتور خالد على الدعوة. وممكن شوية تغيير بقى من الثايرويد سنة نحود على الاوبيسيتي، وهتكلم عن أنا مش لازم هتكلم عن الchildhood obesity، وهحاول اجاوب على الكويستشن can pharmacotherapy be the answer or not. وخليني ابدا، احنا كده وقت الاكل يعني قربنا من وقت الغداء. which is stronger the food or our will؟ الحقيقه الاراده صعبه قوي وخصوصا في الاطفال. and this is what I call the scary future. There is a global public health problem and epidemic. Over 250 million kids are going to be obese by 2030. And Egypt is one of the top 10 in the world in childhood obesity. And this is our pediatric and adolescent obesity clinic, Ain Shams University, Cairo, which I am honored to lead. It was established in the year 2000, and we have a lot of flow with a multidisciplinary team. And this is a case from our pediatric and adolescent obesity clinic, Ain Shams University. This is a 13-year-old girl who was born normal. She started to have progressive weight gain at the age of 6. She has some menstrual irregularities. She dislikes sports, interrupted sleep. Her dad and maternal aunt are obese. There is type 2 diabetes in paternal grandma. She's tall. She has a very large BMI SDS, in addition to a waist-hip ratio being very high. She has abdominal obesity. She's in Tanner stage 2, and her systolic and diastolic blood pressure are high, and you can clearly see the acanthosis nigricans. And when we screened for the lab profile of this girl, we found, as you see in the number, silent type 2 diabetes, although the girl did not complain of any symptoms. She also had dyslipidemia and elevated liver enzymes. So you can clearly see a list of silent comorbidities, which I could call alarming in such a girl. She just came because she's obese, and it turned out to be a list of comorbidities. So it's easy to diagnose this case: exogenous obesity, type 2 diabetes, dyslipidemia, hypertension, fatty liver, and depression. And unfortunately, this is a very sad but common story. فعلا قنبلة موقوتة بقينا نشوفها كلنا كتير. And I think you agree that obesity is only the tip of the iceberg, and there is a long list of comorbidities below the tip of the iceberg. And there is a running vicious circle of comorbidities, whether metabolic abnormalities or other abnormalities, ending by cardiovascular disease. And of course, there is a heavy economic burden of obesity and its comorbidities. We all speak with obese children and their parents about the healthy lifestyle. But when I ask you, do parents follow the lifestyle recommendations? Unfortunately, the answer is a very big no. They do not. And this is the real challenge when dealing with obese children. And you can see here the list of challenges in this adolescent that I showed you. And what we did is that we advised healthy lifestyle and 1-year trial of lifestyle in addition to high dose of metformin, 2,000 milligrams a day. And she failed. She strongly failed. And the question here, can pharmacotherapy be the answer in such a girl? I think yes. So when to go for pharmacotherapy? When could it be the answer? Our aim is to shrink the fat cells. And speaking about adolescent obesity, which way shall we go? We have two extremes, the lifestyle modification and bariatric surgery, which is starting to be an option in adolescent. But we have pharmacotherapy, which fills the gap between lifestyle modification when it fails and bariatric surgery. And you can see the obesity treatment pyramid in adolescents. And again, pharmacotherapy fills the gap in the treatment options, and it's the continuum of care. And the speed of pharmacotherapy options is growing very fast. Before 2019, when I had a case of adolescent obesity, I did not have any pharmacological treatment to offer, simply because it wasn't approved. But now we have a lot of options to offer for children and adolescent. And the cutoff age, as proposed in 2023, is 12 years. You can give pharmacotherapy in obese adolescent 12 years and above. And these are the indications of pharmacotherapy for adolescent obesity proposed by Endocrine Society. Only after failure of intensive lifestyle program for 6 months, both in limiting weight gain and improving obesity comorbidity. So still, lifestyle modification is the first option. We have to try it first. And the use of drugs should be done by experienced doctors. Another nice article in 2021 raised the question, anti-obesity treatment, when to choose it as an option. I think it's really important to balance the risk-benefit ratio. Yes, indeed, obesity is a disease and there is a list of comorbidities. But on the other hand, giving anti-obesity medication has got benefits and risks as well. So the state of the art is to balance the risks of obesity against the risk of medications as well. Another question raised in 2023, when to stop obesity pharmacotherapy in children. When the anti-obesity drug is termed ineffective, and if it fails to safely reduce the BMI Z score by 5% after 12 weeks of consistent use and appropriate dose. So if you reach this criteria, the treatment is not effective and we have to stop the treatment. And this is the timeline of FDA approvals of medication in adults and in children. The ones in blue is for adults, you can see, starting from 2014. And the one in red is for children and adolescent. Our first was 2019, the liraglutide. And in 2020, liraglutide was approved. This is the Saxenda and the setmelanotide. In December 2022, the semaglutide was approved in adolescent and phentermine as well. And then the cycle went on. Now, this slide shows you the list of anti-obesity medications approved in children and adolescent. Of course, orlistat is a very ancient medication. It's approved since the age of 12. The liraglutide approved by FDA, EMA, and NICE. And the semaglutide, the long-acting GLP analog, approved as well from the age of 12. The setmelanotide from the age of 6. And the leptin in congenital leptin deficiency. And please remember, metformin is not an anti-obesity medication. It's approved in children above the age of 8 years for type 2 diabetes, insulin resistance, and polycystic ovary syndrome. And you can see here that anti-obesity medications approved in children have different mechanisms of action, whether GLP analogs like liraglutide and semaglutide, the orlistat, which blocks the fat absorption, phentermine, which suppresses the appetite, or topiramate, which acts on the GABA receptors. Now, the liraglutide is a once-daily human GLP analog which reduces hunger and increases satiety. And this is an article that showed how effective liraglutide increases the satiety and the fullness. Prospective food consumption is decreased and the hunger is decreased as well. And the GLP-1 receptor agonist has got other effects, whether on the brain or decreasing gastric emptying or improving the beta cell function, and that's why it could be given in type 2 diabetes from the age of 10 years, or reducing the cardiovascular risk, and finally decreasing glucose production. And that's why liraglutide in a random controlled trial showed in the New England Journal of Medicine it led to significant reduction in the BMI in children from the age of 12 years and more. You can see here significant change in the BMI over time. But the drawback is rebound. Once we stop the liraglutide, they have rebound increase in the body weight. FDA approved liraglutide in December 2020 for obese adolescents 12 years and more. And then there is a very recent article published last year in 2024 on children below the age of 6 years until the age of 12, which is a very good age group. And there was significant reduction in the BMI in those who were on liraglutide compared to placebo. And the question here, could this be a step for approving liraglutide in children from the age of 6 years? I think so, because the controlled trials is a step, preparatory step before FDA approval. And here you can see significant reduction in the BMI SDS in this age group. And this is a nice article published in 2022. It's a meta-analysis which compared all types of anti-obesity medication. And liraglutide was the best in achieving significant weight loss. Now, this is a research that I was honored to lead at Ain Shams University, testing the liraglutide on metabolic profile in Egyptian obese adolescents. And we included 100 Egyptian obese adolescents. As you see, there was significant reduction in the BMI, SDS, and the waist-hip ratio. The fasting blood sugar and insulin were significantly lower. The total cholesterol, triglyceride, and LDL were lower, and the liver enzymes and ultrasound improved. So yes, it is effective. Now, liraglutide is approved as a long-term treatment in obese adolescents above the age of 12 with or without type 2 diabetes, and this was published by the American Academy of Pediatrics. What about the once-weekly semaglutide? It's more easy and compliant to use, especially in adolescent. A dose of 2.4 milligram plus lifestyle led to significant reduction in the BMI in adolescents. Again, this was published in the New England Journal of Medicine 2022, and after that it was approved in 2022. We compared at Ain Shams University the effect of semaglutide to liraglutide in the same number of children, and semaglutide was more effective in reducing the BMI and the metabolic parameters. Another recent article published the effect of exenatide in 2024. It demonstrated efficacy of exenatide in pediatric and adolescent obesity. Again, it's a GLP-1 receptor agonist approved in type 2 diabetes above the age of 10 and in obesity as well. Of course, orlistat is a very ancient treatment. Long time ago, it was approved. It blocks the fat absorption, but it's a very big problem to have oily diarrhea in a child. It's not easy to use. Now, another article compared in JAMA the effect of anti-obesity medication, and again, liraglutide has the highest odds of achieving weight loss. Now, let me leave the simple obesity and give you more of the taste of pediatrics. This is a 1-year-old infant who came with progressive weight gain. Continuous food seeking, the parents are first cousin, and she has a morbid obese paternal uncle. She also had recurrent infection. She's very obese. Her endocrine profile is completely normal. What do you suggest? What's the most important test in such a baby? What do you think of? Yes, thank you very much. Monogenic obesity, yes. And if you take a closer look into genetic obesity, it's either syndromic or monogenic or polygenic as well. And this is what I call the appetite war. The war between the POMC-CART pathway, which suppresses the appetite, and the neuropeptide Y agouti-related peptide, which is the orexigenic pathway. And whoever wins the war will affect the weight of the child. So how do we stop eating? You can see here that leptin acts on the leptin receptor, stimulating the POMC-CART pathway, which causes the satiety and energy expenditure. So again, there is a regulation due to balance between the leptin and the ghrelin. When the leptin takes the upper hand, the POMC pathway is activated and we stop eating. When ghrelin takes the upper hand, we seek the food. And this is a very long list of the genes incriminated in monogenic obesity. And you can see that the earliest gene was cloned in 1994. And the list continues to grow. And there are emerging strategies for managing genetic obesity, as you see. Remember monogenic obesity if you have severe obesity in the first 5 years of life, especially the 2 years, and if there is other additive dysmorphic features. And these are the POMC mutations due to mutation in the POMC neuron, causing increased appetite in addition to red hair and adrenal insufficiency. And the setmelanotide is melanocortin receptor 4 agonist, which restores the normal appetite, with a lot of clinical trials in this aspect, after which setmelanotide was FDA approved in children above the age of 6. And finally, congenital leptin deficiency, either classical or biologically inactive or antagonistic hormone. And finally, metroleptin was approved for children with congenital leptin deficiency. And you can see here the starting dose. And this is a very recent article showing significant improvement, not only in the appetite, but the motor activity, the mood, and emotional stability as well, caused by hunger. So if I ask you, can pharmacotherapy revert the obesity wheel? I think yes. It can. But the correct choice of treatment is really important, because managing pediatric and adolescent obesity is a real challenge. And you need to be careful when dealing with children, because if you drive the wrong way, you can easily crash. Remember that obesity is sometimes preventable, not always. Genetic obesity is not preventable. And remember, food is the most abused and anxiety drug. احنا بنزعل بناكل، بنفرح بناكل، في كل مناسبة بناكل، فالفود فعلا أكتر حاجة بنعملها. Exercise is the most underutilized antidepressant. So finally, childhood and adolescent obesity is a growing health problem. Anti-obesity medications are expanding. Proper use of the novel anti-obesity modality fills the gap. And remember, obesity is the tip of the iceberg. وهختم بصورة برضو زي الأولانية وهسألكم, which is stronger, the food or our will? برضو الفود. Thank you very much for your attention.
Thank you, Professor.